Welcome back to House Healthcare. We are still on S37, and now we're looking at Section 9, which requires the Green Mountain Care Board and Agency of Human Services to report on access to reproductive and gender-affirming healthcare services as part of ongoing projects and analysis. Section 9 starts on page 16, and we have both AHS and Green Mountain Care Board here to tell us their thoughts. So turn it over to you.
Hello, everyone. I'm Shayla Livingston. I'm the policy director for the Agency of Human Services. I will keep my comments very brief. So the community profiles, just so this committee knows, we're going through a new public engagement process to solicit input from communities about what is actually going to be useful in these community profiles. That work is happening with the health department in conjunction with their state health improvement plan community engagement that they do. There is a period of work for that. It starts in May 2023. It ends in May 2024. The most important thing about the measures and the profiles that are useful to the communities that they serve. So it is really important that we get their input. We also need to, of course, have measures that we can get data for and upload on a regular basis in a consistent manner to the profiles themselves. So with that said, we have absolutely no opposition to considering these measures and looking into these measures. I would ask that we change the shall to a shall consider, just because I don't know exactly how this would work and break down at a community level. Because again, the community profiles themselves have to be done at a local level or else they're not useful. So if it's specific to the community profiles, I would ask for a shall consider or some other wording that gives us a little bit of space in case it's either technical or otherwise that it isn't possible, and we can come back and explain that to you all. If that is what happens. But I don't, we need to let that process play out until we make changes. We're not going to make changes until we get that community input, which again ends in May 2024 at this juncture.
So you talk about the first line on page 16.
You got it.
Yeah.
So a couple questions. Are the community, if we put a shall consider in some community profiles through the public engagement, find that they want that and some don't, you would still do it for some, or that might be consistent across all communities?
That is an excellent question. I cannot answer off the top of my head. I think it needs to be consistent, but I could be wrong.
Okay, so I would love to know that before we consider making that change. And there's no date on this. Is there a date on this? Do you need to go get water?
I don't know. I think the hot air, the dry air is making me. Maybe that's a good idea.
Feel free to go get water.
Sorry.
That's okay.
Alcohols as well.
There's no date on this, so it's not because you're doing the public engagement. You're not concerned.
Yeah, I just want. Yeah, no. There's no date in the language. We just wanted the committee to be aware that we would not be disregarding your input where it's just going to take time. And I think with the shall consider, one thing that we would do is to work with the health department to make sure that it's brought up in those community engagement work. We do already in those profiles. I don't know if the committee has looked at them recently. Have some reproductive health measures already there, but those again we can definitely direct the work to make sure that we ask communities about those measures as in that process, given the timelines.
Can you point us to a link to a community profile?
Yeah,
that'd be great.
Absolutely.
Yeah, if you could send us something, that would be great. Okay, great. Any other questions for Shayla? Topper and then Daisy.
What happens if you have more communities that don't want to do this? What happens then to this whole thing?
That don't want to do the profiles or that don't want these data? I would probably bring that back to you all. I mean, it's really, it's an interesting request from, and the shall, that's why I'm asking for the shall consider, because they are not useful if the communities do not use them. Again, we have no opposition to exploring these. I also don't know, again, at a data level, which measures how we would actually populate the profiles on an ongoing basis, because it also has to be sustainable. and of course, like the entire state government, you are hearing from me because we do not have the position filled right now at the agency that would actually, be looking at these profiles over time. Well, happily, that doesn't matter for the near term because we're doing the public engagement work and we're partnering with the health department. But all of that said, it does need to be something that can happen in a sustainable manner.
Daisy?
Can you give us a little bit of just a brief overview of the implications of the community profiles of health and safety analysis? My understanding is that this data wouldn't necessarily be a grade on a community's
No.
services.
No.
So I'm wondering if you
No.
can speak to what the implication would be of including this data on a community profile.
Okay, yes, no, let me be really clear. It is not a grade. Community profiles, see if I can dig back. It came from this idea that we want to provide a platform that is useful to communities to look at their data for well-being and health in a holistic manner. It is not supposed to be a grade. It is supposed to be a way for community members and providers and people from that area to look at the services, the indicators that are important to them to help drive decision-making for their community. I think it is, I think the genocide for is a really, it's like you want red in one community and green and, that's a judgment right on it versus having access, I think it's, I don't know, it really would depend on those measures and what it was that we were looking at. The other tricky part is, again, because of which measures you would end up including, if it's, do you have it or do you not? That doesn't work as well in this platform, just because it's more about like a gradation and making improvements over time. It could work, we could try to make that work. But then if you get into numbers of people, you don't necessarily want to do that because of small numbers in the state, especially once you get up into certain areas. I don't know if that's helpful or not, but I think it is really important. It's not about a grade. It is about making data meaningful and useful to communities for decision making.
Art?
Yeah, and thank you. I might have totally missed this. I'm trying to understand what a community profile even is.
Do you want to have access? Claire, can you give Shayla access to get on?
Let me see if I can do it.
And does every community have one?
Let me show you. I think it's just gonna be. You did send me the link, didn't you?
Yes, I sent it.
It won't let me. Can I actually just have you pull it up? Because it's just on the website.
Sorry about that.
No, you're
Hate to-
That was my,
Was it?
well, I said, could we see one? And she said she'd send it on. So,
Vermont. Doing that.
Oh, you got it, all right. In our history. Remember, we're still live, everyone.
but your experience of presentation.
Same thing.
I'm
admiring. Oh,
like sharing.
I totally forget.
Okay, so this is a little funny because I'm over here, but I'm just gonna do it really quickly. So you can just Google Community Profiles Vermont. It will bring you to this landing page here. If you scroll down, you can choose which of these buckets you want to look at.
And which one are we looking at?
So you can choose what you want to look at. I'm going to look at equitable access by AHS district, since I think that has the most to do with what we're talking about now. So as you can see, it pops up with a map. You then have to choose your indicator, and it will show you here both a graph at the bottom with the trend as well as the map to the side, and then at the bottom left, it will explain that profile.
Okay, so these services would be shown somewhere on this screen
If we had this, if
Correct.
if you do this.
Depending on how we would do it. So you can see, this is the percent, I mean, all of these are percent of actual Vermonters, right, who get or receive a certain service. This is WIC right here. Actually, which one did I just click on?
Vehicles,
Sorry,
percentage of households with
no vehicle. Thank you. Right up there. So you can see the data source. There's all different data sources on community profiles. And what it means is down here in the left-hand corner. There's data notes for all of them, et cetera. So there's a lot of work that goes into this in terms of the data part of it. It is like semi-interactive. It's not actually live interactive, but you can click on different things. And it is, so again, it's really supposed to be useful to communities.
So Claire, thank you. I think you can take that down. So there's a bunch of questions I'm going to ask. We're going to stick with questions and then I'll go back. Are you done? Ari, and then Leslie, and then Melanie.
Do you think we could compare it to how the census works at least in identifying where there are needs for more resources and the state would then allocate more resources or services to areas that identified need for more equitable access? Does that make sense? So the state makes decisions based on the profile, including whether or not to increase resources or services in certain areas of the state.
Not following your question, I'm so sorry.
So using the data, let's say from equitable access, if the profile showed that there was a problem or inequitable access to gender affirming care, then the state process would include identifying how to resolve that. Maybe add more resources, money or service.
Yes, but you're using the state broadly. And I just want to be clear that this is for communities. So it would be a community response, right? They would say, hey, look, compared to Vermont, it looks like, or compared to other counties or districts, however they're measuring it, you saw you had different options for how you divide up the state there. It looks like we really need to work on this, or we as a community and whatever that group is, however they're coming together, we have identified this as something we can work on and we would like to make progress on it. And again, you can see that change over time. It's not, my hesitation when I saw it in statute, it's not meant to be something that I say, I really want to put this on there because I'm the policy person for AHS. Like the point is for the communities to identify those measures in order to, give them access to their data that is useful over time to make change. It's supposed to be organic from the ground up, not one of the things that we do, and we do many, a little bit more, from like a big state perspective, if that makes sense.
But isn't the state responsible
Daisy.
for sharing? Sorry.
So
Let's let Mari finish her questioning and then.
So the state wouldn't be, AHS, for example, wouldn't, if there was a problem identified in a community profile, it would be the community's responsibility to address that. There would be no resources that AHS would provide the community to address that issue.
I think the disconnect here is like this as an actual tool versus what we do as an agency. If we as an agency were looking at access to gender affirming care and noticed that there was a very large gap or some sort of issue in access somewhere, I am assuming somebody working with providers would identify that and raise that, and we would talk about it. I don't know that it's necessarily going to come from this tool. So I just want us to be really careful about requiring measures in specific tools when I don't know what your goal is. If your goal is for the communities to identify it and bring it to light, I think it is. And again, I'm not opposed to bring it up, and I totally can ask the contractor running the community engagement to please indicate that the legislature is interested in whether or not we want to consider this. If you would like the state to do an analysis, that is a different question. And I just want to be careful about the tools. And so that's really what I'm trying to bring up. It's not that we would ignore some huge gap in the system. It's that this is a really specific thing that we're doing for community level engagement and data. And if we want to just say like, hey, you know what? We want AHS to look at gaps in care and what this access looks like. That's just a different ask. That's all I'm trying to say.
Okay, I guess my concern is that historically, groups of people that are the most vulnerable are maybe the least likely in a community to say, I need these services, I'm not getting these services, this is an issue. And that other members of a community are making decisions for a vulnerable population without input from that population. So I have that concern and wondering what the negative impact would be if we kept the language as is. What do you see as a problem?
So first, it's a really good point and one that we are stressing in this community engagement process. So I just want to say that is true. That is true for state health improvement. It is true for hospital needs assessments. It is true for community profiles. It is true for all the different work that we do around data collection, reporting, and then action from that we need to make sure that we are engaging populations that have historically not been included or could have barriers to participating or coming forward. So that's one piece. I'm not saying we're going to solve that probably in one go, but definitely very central to the work that the health department's doing on the community engagement front for both projects. The other flip side of it is we don't require other things in the community profiles. So this is the only thing that's required. And again, I don't know what the data source would be. So you saw a bunch of those data sources. They're traditional data sources that we can draw from as an agency. I can't tell you right now, and I don't have a person to do the work to tell you what would that data source look like? What does access mean? Do we, all the questions around where we get the data and how we upload it and who shares it, et cetera, et cetera. I just don't have that. So in requiring it, you can require it. We will tell communities it's part of the deal because the legislature required it. And then we will try to figure out how to get it in there from a technical perspective. Again, I just want to ask the committee what your goal is. Because if your goal is, hey, Shayla, we want the agency to identify where there's gaps in these services, I just feel like that's a different question. It's just not community profiles.
Let's come back to that. Leslie? Well, I know, but we're going to come back to it because I'm interested in that too.
Okay,
so
good.
specific to community profiles.
Yeah. Well, I'm looking here at this language, and I just was looking at reproductive health care services, and I'm not understanding how you get your data at all, because I'm looking at the profile, and a lot of it's from 2011 to 2015. So clearly, we're behind on that, and I don't know how that could. And maybe that's what this process is for, is to get us to 2023, which would be fantastic, right? But right now, we're way behind. But I was also wondering about access to reproductive healthcare services, which may include pap smears. Or I come from the Springfield Hospital area, the whole GYN system kind of fled, so there's not access. So how do we figure that out? And so in a way, I'm just wondering, when we take away the shall consider, do we lose access to other things that are important for reproductive healthcare?
So again, I think maybe what I need to do is come back for the committee with all the different ways that we show data. community profiles are grant funded, legislature doesn't fund it. The grant funding went away, we applied for another grant, we got the other grant. We're now doing the engagement process because we have the money. Since we don't have that grant money anymore, I'll come back in here and be like,
But we gave you money, Russ, 4 million, does that?
That's not for this.
so I just, again, just really trying to dig into the where you want this and why you want it. And the Green Mountain Care Board can actually speak to some of the other ways that we look at access that are ongoing and that are really specific to care versus this, which is not specific to care. Sorry to keep coming back to that. Again, I'm not opposed. I want to be really clear. We're not opposed to looking at this. I'm just not sure it's the tool. There are other tools. I'm happy to come forward with other tools that might be more, that might fit this better if I can just get at what the committee's goal is a little bit clearer.
Can I just ask a question on this topic? I'm just trying, I don't know why the section, how the sketch bill got written. So I don't know what this section was hoping for, like where it came from or why it's here. And I don't know if this is the time to think about that, but I'm curious about it.
So this came from the Senate. So we don't know why. I mean, this is a Senate bill, right?
Okay.
So what's our intent now?
So we have to try to understand their intent or not worry about it.
Or we can try and understand their intent. We could probably ask Jessa potentially. Or we focus on what our intent should be as well.
That's helpful.
Yeah, so there's a whole lot of questions. Melanie?
I guess I'm unclear as to how all of the indicators and things that you're measuring got put on there in the first place. Like how were those determined? And then also, I'm confused as to why it's something it would be beneficial to do the shall consider when this is important data. And I hear what you're saying. When you have a tool that is like that has so much information on it, why it wouldn't be useful to have this as well in it. And I'm not hearing you say that it wouldn't be useful, but I'm confused.
So I'm not saying it wouldn't be useful.
Yeah.
I'm saying I don't know how we would do it yet. And that I think there are so we have a lot of data like this on the website. We have Healthy Vermonters 2020, which is being updated. We have the Safe Plan. We have dashboards for departments. We have the many reports and ongoing measures done by by my colleagues at the Green Mountain Care Board. So this is just a small thing. It is grant funded. Doesn't have ongoing base funding necessarily. And the way that the measures are identified is by community engagement, which is process we're starting again in May. So it's not, it's different than many of our other ones. I would say Healthy Vermonters 2020, that comes from, in some ways, CDC, but then there's a whole host of, again, community engagement process through that. And I'll let Green Mountain Care Board talk about theirs, because I definitely am not an expert on that. But again, I just think that there are so many different places we put this information, that this project specifically just might not be, again, depending on what your goal is, the best fit, and we can find a different fit that's equally accessible, online, clickable, same actually tool, same, software, all that good stuff.
Daisy?
I think, looking at that community profile, it's a beautiful tool. I'm a big fan of maps. And I think, in the name of, equitable access to healthcare that's spelled out right here on line 21, I think that's an extraordinary tool to do that with. And I think it's in the state's best interest for, doing that in a cost-effective way, that we share data with communities so they can make informed investments locally as well as us on a state level. Also, I'm noticing that services are linked to this. So when we think about where is the data at, it's in service codes and billing codes, right?
Depends on the measure. Some of it's community, like some of it's census data. Oh, sorry.
Specific to this, the healthcare services and reproductive services are in billing codes. So I would just give you that food for thought.
YRBS, right?
Take back around these healthcare and reproductive services. Take back, and I know that you and Lori will talk about coming back, but I would suspect that is a kind of treasure trove of data, since a lot of our population is on Medicaid in these places. And I think the culmination of, what I would hope to see from that is not only sharing and transparency and data, but also, better ability for communities to have more clarity in what they're asking for from the state when they say, we have this community need. And I think we all know what that's like for constituents, and as a policy director, when you have a constituent or when you have a community that says, we have a serious need, we don't have any women's services in our community, they have the data at their fingertips. And I think this tool and this Section 9 actually is speaking to that. From my perspective, that's what I'm reading into this.
So again, I think it really depends. So like, not to get data wonky on you, but like, do you want access to care? Do you want receiving services? So like if you're using insured data and claims data, you're only going to get people who are covered by insurance, and you're only going to get services that were accessed, and you'll get services that were accessed outside of that area. If you want access to services in that area, going to your point, then you'd actually need to look at services provided by provider type, not by billing code. If you wanted to look at whether or not people are actually going to care, or if they're worried about care, you'd go to like a survey level data. So I think it really, that's the kind of information that you would want to suss out from a community at a community level. Is it concerning to you? Like, yes, just make something up. The women's services, women's health services are no longer, pap smears are no longer available at Springfield Hospital.
That's
I'm gonna pretend. We're just gonna pretend.
This is just, for the argument.
For argument's sake.
Yeah.
And maybe the community is like, that is not okay. That means that fewer of our people are getting them on annually. This is not working for us. We want to look at this. This is important. Versus, oh, that's actually not that big a deal. We just go to Dartmouth for those, and like, it's fine. That's not the issue. The issue is whatever. That's going to really change. To your point, what are we using as the data source, and what are we actually measuring because like reproductive health measures are.
Yes, but Shayla, my point is that a lot of the data that could potentially feed this wonderful tool that we've already invested in via what grant? CDC? Whatever.
Sorry.
It's fantastic. We should leverage what is already existing to learn more about our communities and make great investments based on that. That data already is in DIVA, a lot of it, right?
So in a lot of it, that's what I'm trying to say, like a lot of it is reported in other places. So like DIVA has it, like we have dashboards and reports and that are not the community profiles, that are like department level dashboards and websites that are, again, I'll go back to my Green Mountain Care Board friends that are, in the reports that they generate. So that's where I think the naming community profiles specifically might not get what you want, because if the grant goes away and then to your points again, 2015 data, I'm not sure you're achieving your goal. Maybe you are, and that's fine. And again, not opposed. I'm trying to ask you, what is the goal? What is the purpose? And then what is the right tool to meet that goal? And if it's something that's going to be really sustainable, ongoing, this may or may not meet that. We're going to try to make it sustainable and ongoing because we all like it.
Yeah.
I can't guarantee that.
Okay. So Brian, and then we got to go to Green Mountain Care Board, but we're going to come back to this.
I can't remember what my question was now.
Okay, sorry.
Right.
From my perspective, I think what's really important is that if some communities want it, they should be able to have it. So that question I asked, like how do you determine what's included, would be really helpful. And if we change the language to shall consider, I'd like to add language of what happens if the community profile process doesn't happen. But I think we need to have a conversation around this table about what the intent is and what we want. So we will do that Friday and get back to you on that.
And I will send you a link of other online maps and resources so that you guys can explore those on your own to see what else is available in terms of reporting, data reporting from the agency.
All right, thank you, Brian.
I remembered.
Wait, hold on, Sheila. Brian.
I remembered. Well, it's not really a question for you as much as like just it goes back to the issue of intent that in the past I have seen a practice here where the Senate or the House will invite someone from the other committee to come in and.
Yes,
talk.
and we can do that too.
All right.
Yes, yeah.
So, and it might just be good because this feels like I need
What
to
the
think
intent
about.
was.
Yeah, I
Yeah.
just want to know that before we totally.
Okay, definitely. Thanks, Shayla.
Thanks.
Hi, Veronica. Thank you for waiting.
Of course, no problem. Good morning.
Welcome to House Healthcare. I don't think we've met you yet, so welcome. And if we have, I apologize for not remembering. So we're still on section 9, but we're on 9B specifically. So I'm going to turn it over to you to introduce yourself and your testimony.
Great. Good morning. I'm Veronica Fialkowski, Director of Data Analytics Management and Data Integrity at Green Mountain Care Board. In my role, I help manage all payer claims data and hospital discharge data, and also help manage the Health Resource Allocation Plan, which I'll refer to HRAP moving forward.
Yep.
I've come prepared to give a brief background about HRAP and how this language in the bill fits into HRAP. The language in Section 9B directs the Green Mountain Care Board to include reproductive health care services and gender affirming services in the Health Resource Allocation Plan, and we are supportive of how the language is written. I know there are some folks who are probably really familiar with HRAP and some that may be less familiar. I just want to provide some very high level information. HRAP has been around for about 20 years, and it was first published in 2005. HRAP has taken multiple forms over the years, and I personally find the name a little bit confusing because at a high level, HRAP is really a collection of resources to support identifying healthcare needs rather than a plan per se. GMCB hosts HRAP per Vermont Statute 18 VSA 9405. HRAP is intended to capture what is happening in the state in terms of healthcare services, accessibility, quality, and cost, and then provide some recommendations on how to allocate healthcare resources. HRAP includes dashboards and reports, needs assessments, inventories from Green Mountain Care Board data, Agency of Human Services, Vermont Department of Health, and other partners. By packaging available data and reports from across state government, HRAP can support the GMCB regulatory work such as Certificate of Need, and also serves as a resource for healthcare projects or decision-making across state government. I think it's really important to remember that HRAP is not a single document or published at one single time. It really includes inventories, reports, assessment, et cetera, that may have been maybe a one-time project or a recurring report or inventory. The GMCB's website has a page called Health Resource Allocation Plan, which houses these resources where you can view some of these interactive reports and available data. For example, GMCB worked with different entities to compile inventories that were updated in 2019 and 2020, which just for a couple of examples include mental health, oral health, and some health, home health and long-term care. If the bill is passed, we will prioritize reproductive health care services and gender affirming care services in HRAP reporting. We, the GMCB, do supply data. We steward hospital discharge data, which is known as BUDS, or claims data known as BCures for HRAP, and have done some inventories, but we will also heavily have to rely on partner agencies to fill the gaps to assess need. Those two data sets alone can't do that. Precautions are always taken related to de-identified data and how we deal with small numbers. Of course, this will be true here as well. And please note that there are extra sensitivities around handling data regarding these topics. These topics are sensitive and there are additional protections. So we'll face some challenges and limitations with what we will be able to provide. But with that being said, information as outlined in this bill will be incorporated into HRAP. Thank you, and I'll take any questions.
Great, thank you. Any questions? We're a little, can you mute Veronica while you're not talking? That would be great. There's some echoing. Brian?
So I have a question, and it might go beyond the scope of what you can answer. So if so, just, it's okay. And then we can figure it out. But like, as I was reading this and thinking about it, it brought up something we heard from a witness the other day about how, we're talking about trying to make sure people have access to abortions and contraception. but what about prenatal care and pregnancy services so that people don't feel like they don't have a choice to have a child if they really want to because of economic issues? So I guess like, I'm curious if, because this is very broad language, like would it include prenatal care and other pregnancy services? And then this is the part where I think it might go beyond, like, it might exceed like the programming of the Green Mountain Care Board, but it might not, which is, what about the other socioeconomic factors that influence people's decisions? Like people not having enough money to take care of the kid that they want and feeling like they're not going to like to support their child. So they're kind of have to give it up or terminate a pregnancy. So I guess that might go beyond the scope of this piece, but it came to mind thinking about this, like we really need to be thinking about the socioeconomic factors and the social determinants of health, like housing and access to food and et cetera, that might make a person feel like it's impossible for them to have a child that they want. So I don't know. I know one a little further, but I'm curious, like from the perspective of the board, like if it would include some of these things.
Sure. So I think for the first, maybe year, first part of this project, it would really be looking at the services that are provided as is, utilizing the data that we have or, can work with partners to obtain. ATRAP includes other data from other agencies. So for example, we tie into like what we just heard from Shayla about community profiles, which may have some of this information, the social determinants of health that influence care and so forth in it. And so maybe it might not be, it's under the purview of Green Mountain Care Board to make those associations, but the data may be available for some of that. But I think as like the first step in this is just to identify the services.
Okay.
Great, thank you.
Thank you.
Any other questions, Art?
I'm gonna follow up on that. When I see reproductive health care services, I would hope they include the prenatal care and some of the things that come with having a child, having a baby. Do you know if they do? I mean, are we just making this about abortion, or are we being fair to all sides here in terms of reproduction?
Yeah, I think we can define reproductive health care as needed to be most useful for, for this process and for certificate of need and et cetera. In both the claims database and hospital discharge data set, it will include more than just abortion services. Really, we actually have limited information on abortion services because there are extra protections around that data. And within the hospital discharge database, hospital-based abortions are, I think, comprise a small amount. And so I think having some focus on other services in reproductive health is possible.
And I want to go back to the definition on page 3. Reproductive health care services means all supplies, care, and services of a medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature relating to pregnancy, contraception, assisted reproduction, pregnancy loss management, or the termination of a pregnancy. So that to me captures all of them. I'm sorry, go ahead. Am I not doing that right?
Amber Navajoli, Legislative Council. Section 10 does not pull in those definitions.
Okay, but section 9
does not pull in the definitions from 1 VSA 150 that we're creating.
Thank you.
So if you would like more specificity in there as to what types of reproductive health care you want looked into, then we can either use that definition from 1 VSA 150 at the beginning of the bill that you just read, or custom tailor one that suits your intent for this.
Okay.
So my question is, we passed some legislation a couple of years ago, I think it was now. And I think there was a definition of reproductive health care in that bill that we passed. It's now, I can't remember what act it is. Remember the first, Jen, do you remember the first bill we did? prior to opposition. There was a bill that was done.
Jennifer Kirby, Legislative Counsel. I think you were talking about the reproductive rights language in, that's one of the definitions that is getting pulled into the statute, but it does not specifically define reproductive healthcare. It talks about rights of individuals.
Okay.
As far as how to.
Okay, so this one does a better job of defining what it is.
Well, this is that one is not a definition. I think that you're talking about Act 47 from 2019.
Yeah.
Right. The only definitions in there are of healthcare provider and public entity. And then the content of the chapter talks a fair amount about the various options, but doesn't define.
Okay, thank you. So that's.
Yeah. Okay, so we have a couple things on this section. We have to hear from the Senate on what their intent is and then determine if that's our intent. And then look at what the definition for reproductive healthcare access should be in regards to section 9. Leslie?
I was just wondering, Veronica, if you have similar concerns about the word shall.
So section A just replies to HS.
Right.
Section B, section B and the shall. Go ahead, Veronica, sorry.
Oh, no problem. In section B, we are supportive of how the language was written. So,
thank you.
No concern.
Any other questions for Veronica? Great, thank you so much, Veronica, for your time, and I appreciate you waiting. So we'll come back to this. We'll get some additional information from AHS. And as part of our committee discussion on Friday, we'll come back to this section and potentially hear from the Senate by then as well. So we'll try and figure that out. Okay, so I think we are done with this for today. We're not done with this for today. We will come back 15 minutes after the floor and hear from Vermont Family Alliance. So 15 minutes after the floor,